And I think you guys have already heard this talk. It was by Jim Duddle. But basically, he made the case persuasively to many of the medical directors from the plans and from the provider groups that, you know what, you can actually achieve 70% reductions in a few years. And long story short, that was kind of enough to capture the attention and imagination of a lot of different systems, and they were willing to at least meet and start to play. And some of them actually started to adopt this and roll it out. Around the same time, as Keith was sort of talking about, you know, how do you, often people kind of, you know, the doctors, we know we tell them you got to do stuff around your hypertension or around diabetes or whatever, and it doesn't necessarily have any impact. And so, and we also wanted to get a rallying sort of, you know, approach of something that would be a kind of audacious and catch the attention of a lot of the participants and get them excited. And so one of the things that came out of the early discussions was a decision to sort of throw the hat over the wall and say, you know what, let's make San Diego the first heart attack stroke-free zone in the country. And it was like, that was kind of silly in one sense, and yet it gave them a clear goal that they were working for, and immediately kind of led to the discussion of, if you're going to do that, and if you're going to say get a vast reduction in, you know, 3 or 4 years, what do we need to do, and what kinds of things would that take? This is actually a campaign that came out of that, and for motivating the patients, it was pretty evocative in terms of, here you're seeing the things I miss most, Dad, is our heart to hearts, and so the dad is basically, he's dead, but you know, you have a ghost of his figure. Here's another one, you know, his first perfect wave, you want to be there. And so whether for, you know, primary, secondary prevention, or even cardiac rehab, it was intended to really motivate patients in the community. It also just motivated, surprisingly, and inspired a lot of the practitioners around there, and really they're like, this could be fun, this is really unreasonable, but sure, let's play. Part of what also helped the different systems achieve the kind of performance individually and change individually, but also the population level changes we saw was collaboration, much sort of starting like this, but this is actually from one of the participants, Parag Aranguri, I can never pronounce his name, but he was at the time the medical director for Sharp Riesli Steely, which was one of the well-performing groups at the beginning, but they managed to improve a great deal more. And what he and others really saw it as was it was a chance to start to meet with their colleagues, their competitors, and start to share notes, and then actually, despite being competitors, do something collectively together. It didn't hurt to have it start at a beautiful setting. This was Scripps. Hattie or somebody arranged to have it meet, you know, right by the Scripps Pier in San Diego. And so
I found that out on a morning run out back before I broke my ankle. And it wasn't even finished being constructed yet. And I'd had it in my mind's eye for years. So I think it was something that people were really drawn to.
It's hard, and it's you know, eventually outgrew that after a few years, but it was a good place to start. I'm gonna skip that, just other than know there were lots of provider groups, health plans, grocery stores with the pharmacist. It was the county of San Diego, or the Health and Human Services played, a huge role over time in terms of helping fund some of it. And in general, it was, it took a village. But so the other thing that started to happen is, based on some of the stuff Jim Duddle and Kaiser had been doing, there was agreement on, not so much that every system there would have to do exactly the specified sort of approach, but that they would put together simple documents and materials that could be shared with other providers, with other systems, and start to help disseminate and scale up some of best practices. And later, there were other kinds of things that, team management, or how do you have a good healthcare team, and automated blood pressure cuffs. But early on, this sort of stuff of focusing on, whatever you do, just get them on these medications and titrate up, or at least something like it. As I mentioned, we also, besides the main University of Best Practices, we formed some working groups, and one of them that I worked a lot with was around the goal of starting to share some data so that we could track and not only the progress, but also assess where there might be some opportunities. And it took a while to get the data, but truth be told, the data that we were initially asking for really and requested in the first few years was basically data that the providers and plans were already having to produce and provide to the IHA or accreditation agencies or whatever, as value-based care sort of emerged. Some of it was already publicly reported, but there was huge trust issues in terms of actually getting the systems to play together. But here's a list of some of the groups that participated, and just the thing to know is there was a diverse range of, some of the large, high-performing integrated systems, as well as some IPAs, and then community clinics, which at first and second glance, there was some concern that really there wouldn't be much to share between them because of their different populations. But in fact, over time, they found a lot of commonalities in terms of what they were doing, and usually each different system participating would have something to contribute, and they just cross-fertilized. Just to give you also a sense of, we weren't tracking the whole population, at least with this data, but very quickly, it became a pretty big population. We had about 200,000 hypertension patients and 100,000 diabetics that we were following, and effectively kind of a registry of where we didn't yet have individual level data, but we at least were tracking the progress. And that was, approximately, say, 1 in 3 of the hypertensives in the county. And even, whatever was happening at the population level, it was a big enough group and numbers so that, for, say, a 2% gain in the overall hypertension control rates, it would translate to about 4,000 more patients having blood pressure control. Really quickly on the measures, again, it was just kind of basic, almost HEDIS-like measures. We focused on some more than others. In particular, we eventually decided to focus mostly on hypertension. And when I say we decided, it was essentially a discussion between the different provider systems, and they agreed this was a priority, or there was, both internally and there was national initiatives going on. And many of them sort of felt like they didn't know how to do hypertension, or it was, at the time, it was very hard to and to actually even track all their hypertensive patients. We also had some ability to stratify it by variables like age and sex and zip code, and so forth. What the data you're seeing, or we're seeing, is usually we did it all payer, and then we can also stratify it a little bit by payers. Other stuff in terms of, we didn't actually try to, I mean, we go through root cause analysis and people would share their different barriers in the systems, but ultimately, often we would adopt a, something that was already well designed, and some of the systems we're participating in already, such as measure up, pressure down, and you know, those things pretty much covered all the issues we had hit, and you know, they were already committed to it, and so that worked very well. There's a little bit on some of the work in that particular, the data group. Just briefly, it established, you know, was established to create a safe venue for data sharing and foster collaboration on efforts to make San Diego a heart attack and stroke-free zone. It had the traditional focus of some of the quality collaboratives on improving performance within the individual organizations. But what was a little bit unique was the amount of emphasis on trends in the combined data, and really seeing what the collective impact was on the population. And you know, over time, it really didn't matter who was doing best. It mattered as much that, you know, even the, you know, community clinics were contributing to moving the overall needle, and sometimes with the most difficult to treat populations. And anyways, that collaboration and sort of the face-to-face and sometimes sharing food helped immensely. Just very briefly, we were able to do some things that, even though the provider groups and over time had better and better population health platforms, what was hard for them to see is, you know, how did they compare to other groups, sorry, in particular areas or with particular subgroups. And so we were able to both do data stuff that would show their own data and how they were doing, say with some mapping and, you know, what it looked like in different areas or zip codes or with different genders, and later do race, ethnicity. We could also do various forms of hotspotting. In this case, it's actually looking for areas where there are, you know, most of the patients are, and the performance is very low. So for example, southeastern San Diego is a lot like South LA here, and that became the target of a grant-funded effort to work with many of the churches, and primarily African-American churches, and they took on that, the sort of the be there idea of you want to be there, and came up with things that work for their own community, and so forth. The other thing I want to highlight is, you know, besides the actual improvements in AMI events, it really was surprising just how the individual groups, even the ones that were performing pretty well, continued to improve, and at times they just have periods where they get innovative and move the rates much higher. And basically what you're looking at is, on the right is, I think, you know, Q1 2015 rates versus the red, that's the blue, is versus the red is Q4 2016. And the thing to notice is, say on BD and so forth, there are some groups that, you know, in a short period of time seemingly really did move their the rates up quite a bit. It's also most of the systems, or at least the bigger ones, did meet that 80% goal, which was pretty ambitious given that the national 90th percentile was only 76%. But even on the some of the other clinics, and many of those you saw to the right were community clinics, some of them also did achieve not only the goals around hypertension. This is the group on the right, group 10, is one that did very well on hypertension and blood pressure control in diabetics. But they were doing better on some of the hemoglobin A1C control measures. That wasn't really a focus of the effort, but even some of the bigger systems really weren't doing so great on that. So that's where you started to get teaching. I just wanted to end with showing you a trend line for the AMI hospitalizations. For what you've seen on the bottom is the San Diego trend, and on top, that's Los Angeles. In basically, at least through 2016, Los Angeles, in terms of their AMI rates, has kind of been flat, and there hasn't been much change, even though there are efforts going on, and some of the systems are doing well individually. So, the question I'd leave you with, and it doesn't have to be settled now, or what can take years, but how do we move the needle in parts or all of LA County? Thank you.
At your places, you have these gold bar charts, and this data is from 2017. So when I initially went to medical groups in San Diego, and I brought this data to them, they said, well, it's old, it's not accurate. And so then Alan convinced our group to really invest in more real-time data. It might have been 6 months old, but it was the best data that they had. And they were much more convinced of its accuracy. And that largely helped move the needle. So although they only collected data on what he showed, we did stick to the goals that are in this group, which are basically on the 3 key metrics of LDL 100, which our chairman, Anthony DeMaria, raised and pounded on at every single meeting. So they might not have been collecting data on it after the national body stopped collecting LDL 100, but by then the medical groups really understood the significance of it. And I think it had a huge impact. And that when you saw that inflection point, that was in part because they stopped collecting LDL 100. The other thing about Alan's slides, and he and I have been working on this together since 2009, and the way we were able to do the much more intensive treatment in San Diego is that Alan worked with our co-PI at UCLA, Dr. Bob Kaplan, sorry, who got an NIH grant to fund very significantly more intensive efforts in that one community. So the VA and the Navy were also very involved, but they couldn't give data officially because of the federal rules. So anyway, this guy was able to cajole them out of their data through a very protected group process where those who had not signed non-disclosure agreements were not able to be in the room or see the data. So it's created quite a esprit de corps there.
Just one other thing, and just two things. So one, in terms of the aggregate data or the stuff that is already being reported, what nowadays, part of the goal was to sort of build in-house capacity there and let some of, basically have it run on its own. So, what now they have their own medical director, and we did some pilots, and basically now the systems, at least those that can, report individual level data, real-time data, and they're actually, we're still waiting a little bit, but there's a regional information system that all the groups have business associate agreements with and privacy agreements, and so it's evolving into where, you know, some of the data and the analysis like we've been doing would potentially happen straight out of that, you know, kind of real time, so they can actually see the data. I'm going to stop there. Thanks.
That was great. Thank you for that. I think for those of us who've been back in the early 2000s with all of this and looking at data, originally data was sort of a four-letter word that we didn't quite know how to deal with it, or did we trust it, and you know, how much could we use it. I think it's certainly evolved into a good four-letter word, if well obtained and well studied, as you've proven. One of the things in looking at the chart with some of the groups, the individual datas and how some of them have really improved. Were you ever able to, or try to figure out what those groups were doing that made them able to increase their, going from 70 to 80%?
They're all on this triangle.
Right.
This is the synthesis of the interventions. And, yeah, so pharmacists on the care team.
Oh, I mean, can you like hone it down to like three things, maybe, like
so,
rule of three?
well, I mean, so first I'd say there were a variety of things that were very tailored to the you know, each of the systems, and often they'd share after, you know, just like in a quality collaborative, they would share with the others, sometimes even give their whole playbook on what they did. I mean, honestly, the key was it became a priority, and they shined the light on it, and the medical director made it clear that we can do better. And the other thing that happened is, you know, while there was lots of collegiality, it was friendly competition. And so they kind of kept outdoing each other. But, you know, many of them, like, for example, Sharp that I showed, and they improved a lot, they actually really adopted and implemented a lot of the planks, the types of changes that were in the measure up, you know, pressure down. And, you know, it'd be things like bring the person back within a certain amount of weeks, you know, have, you know, a much more user-friendly registry, get them on, you know, the appropriate medications and so forth. I mean, none of it, in my estimation, was sort of rocket science. It was kind of things that they were system level issues, and getting the physicians or the you know, nurse practitioners focused on it. The other thing I kind of noticed is you know, an idea would be shared and they'd steal it.
And they did that intentionally. There
Yeah,
was a
it was good.
mentoring process.
It was.
And there was unblinded performance data. So that was one of the early presentations that really changed a lot of the dynamics.
The good competition.
Right. There were other things which we could cover at another meeting, but thank you. I want to give you guys a chance.
I mean, we were just talking, and I think one of the challenges I've seen is if you try to run quality improvement studies as randomized controlled trials, you lose that sense of community. And I think it's really important. So that's a big challenge, again, which we can talk for hours about afterwards. But thank you very much, and I think we will all want to follow up at the end. But we need to move on because we have two more amazing speakers, and I'd like to introduce Dr. Riya Pulicharam, who is the National Medical Director, Population Health Management and Clinical Outcomes Lead for Healthcare Partners, and she's going to talk to us about innovations in cardiac rehabilitation. So thank you, Riya.
Thank you. Thank you for having me back. And you know, I was looking at all the paperwork that was kept there and some of your slides, Dr. Allen, and I did find healthcare partners a lot in there. So I was kind of thinking, you know, maybe I came to this group accidentally, and I don't know who you guys were interacting before with. And I was so amazed last time that I was trying to put together nationally a group to do some RightCare initiatives, and I didn't know that you guys were so progressed already. So I'm so happy that, I'm back here, and, this is my first time coming and speaking to you guys. And I thought this meeting would be to talk about what we're doing with cardiac rehab. A little bit of background, a little bit of what are some of the technology stuff, innovative stuff that we're doing. And I'm so happy to see a lot of data, and going forward when I present, I have to bring a lot of internal data. That's what Haiti told me. So if a lot of data is not here, please email me, ask me. I'm ready to give you all the information, because it's really great work that you guys are putting into there. So today I will talk a little bit on the background of why cardiac rehab is so important, where we are, where we used to be, and where we should be going. The cost of all that care, if we don't do it, if we do it. There's a particular project that was discussed internally on the Million Hearts Initiative, so I'll talk a little bit on that. One thing I did promise Haiti that I would do last time was I will internally hold some focus groups with some doctors, with some patients who went through cardiac rehab and why they quit, and some medical directors. And so I put together a healthy team, and then I went from team to team to see what did they really understand about cardiac rehab. And I have to admit, I didn't know too much about it either. I was just asked to do this pilot, which we started a few months ago. So I'll talk a little bit about the pilot, the technology in cardiac rehab, an HCP pilot. And also I will showcase a little bit about cardiac failure program that we did, and what were those results. So as we all know, cardiac rehab is underutilized, unfortunately. The 67% survives heart attack but does not register for cardiac rehab. The 33% that survives and registers, you can see only 5% complete the program. And we have that same exact number for us. And I was very sad to hear and learn that. I said, that's the national, and we are such a progressive organization, and we ourselves have the same, and they're like, what can we do? Patients maybe not motivated, and Dr. Keith Emmons spoke about it, and it was so something that I didn't really think that was so important, even when I designed the project. But because I had to come and present and I had to do this background information, I was like, oh my God, we're trying to do all sorts of fancy stuff and everything, but the simple things like this, we take it for granted or we don't pay much attention, right? 30% heart attack survivors will have a second heart event. That increases the risk of death, increase of costly treatments. And I don't think many of these acute MI patients, when they discharge, they know a lot of those things. Many of them are not even told about cardiac rehab. So when you look at healthcare cost, about 1 out of every $6 spent on healthcare in the US is spent on cardiovascular disease, which equates to $320 billion a year. In the first 90 days following a heart attack, there's an average of more than 38,000. Medicare spends about $14,000 per patient on hospital bills, or maybe more, over the course of the year following an attack. So that's an increase you can see, a 4% a year. The Million Hearts Initiative was, events over 5 years. The focus of the initiative is to achieve more than 70% performance in ABCs, that aspirin, BP reduction, cholesterol lowering, and tobacco cessation. Increasing cardiac rehab participation from 20% to 70% would save 25,000 lives and prevent 180,000 hospitalization annually in the US. But that's a huge jump. If we're only 5%, we still have a long way to go. Right? So these are the ABCs and more that we are following, the aspect of the physical activity. You know, in theory, these are the things that we are following.